Hello everyone, this is my presentation on my article. The article is Correlates and Determinants of Physical Activity Among Older Adults of Lower versus Higher Socioeconomic Statuses, a Systematic Review and Meta-Analysis. The research phase is number 3, as physical activity levels in different, in my case the topic, socioeconomic statuses. The research area, it's physical activity levels in low versus high socioeconomic statuses. This is the authors, and the affiliations are University of Bath and Bristol in the UK. This is the journal. The journal is the International Journal of Behavioral Nutrition and Physical Activity. Impact factor, at least from 2024, is about 5.5. It's pretty good. Not like the 10 you want to see, but at least it's above 3. And then copy and pasted from the website. IJBMPA is devoted to furthering the understanding of the behavioral aspects of diet and physical activity and is unique in its inclusion of multiple levels of analysis and its inclusion of epidemiology, behavioral, theoretical, and measurement research areas. A quick introduction to the article. Regular physical activity is crucial for health aging, yet persistent socioeconomic status, SES, gap exists. Older adults from lower SES backgrounds are consistently less active, leading to significant health inequalities. And while the existence of this gap is well known, the underlying reasons for differences between physical activity between a gap are less clear. The purpose of the article is to systematically identify and compare the modifiable factors associated with physical activity among UK older adults of lower versus higher socioeconomic statuses, and also is to determine if socioeconomic status moderates the relationship between key correlates in physical activity behavior, thereby informing more equitable public health interventions. As for the methods of the article, the design is obviously a systematic review and meta-analysis, and it was registered with Prospero. The data sources, they used about 5 electronic databases listed there. They started their search from around December 2023, and they only included published peer-reviewed studies in English. The participants they were looking for were community dwellings of adults aged 60 years and older, mainly located in the UK, and the populations were stratified into lower socioeconomic statuses and higher ones based on a hierarchy of indicators, which are very common known socioeconomic status indicators, which is like income, area, depression, education, and just general class. And the primary outcomes that I was looking for is any measure of physical activity that could be the overall physical activity, the moderate to vigorous, leisure time physical activity, just anything related to PA. And device-based measures were prioritized over self-report when available, but self-report still was included. And analysis, they did separate meta-analysis. They did inverse variance random effects model that were run independently from lower social economics and higher ones. The effect sizes, they had used standardized mean differences for the pool results, and for the framework, the findings were structured using the capability, opportunity, motivation, and behavior COM-B model, which I'll show you when we get to the figures. Here is the flow diagram for the methods. This is the Prisma flow diagram that they followed. They followed all the rules of Prisma. As you can see, won't go too much into it, but it's very classic, like either the studies that were excluded were just wrong studies, duplicate studies, wasn't related to the topic at hand, and ultimately they came with about 77 quantitative data and about 30 qualitative data that were included in the end. As for the included studies, I didn't really put all of them because there were about over 100 included studies. That Google Doc was about 30 pages long, so I couldn't really put them all on one slide, but they did do a risk of bias for all the included studies to make sure their studies were good and to make sure that their studies were usable in their analysis. And many of them passed pretty well with this randomized controlled trials and wherever it is either non-randomized or not. And a lot of them, I would say, were pretty usable. Here are the results. The results basically boils down to the fact that between the two different socioeconomic statuses, they have pretty much the same exact reasons of why they would do physical activity and the same amount of benefits from physical activity in this essentially the same amount of physical activity, but the difference is disparity in their ability to access these physical activity facilities. So some common correlates from all the socioeconomic status groups Same key factors were, strongly associated with higher PA levels for both lower and higher ones. These include better physical function, greater social participation. That's like go in groups and just like general, like being around people who also like it. Better perceived general health. These are all strong correlates. Some other shared factors are better memory, higher health literacy, fewer depressive symptoms, low BMI, and higher fruits as vegetable consumption. And basically, what the article found was it was pretty much an opportunity gap where the relationship between these factors and physical activity are similar across groups, but a significant smaller portion of low SES older adults have access to these positive correlates, good health, social participation, because either their area they live in don't have it. And so socioeconomic status specific, so for lower ones, generally are presence of built physical activity facilities. These are gyms, pools, access to walking to cycling infrastructure. And another one that was very interesting was only this lower socioeconomic status group had the positive effect of smoking less, which is, nice to see. So moving on to the actual figures. So the first figure was using their COM-B correlates with physical activity in older adults, and this they separated by socioeconomic statuses. As you can see, generally what you see here is if they're on the right side, it's better, more physical activity because of whatever the reasoning is. And as you can see, just based off of just a general look, all of them are pretty similar from where they are significant in how they move across the spectrum. As you can see, physical function, stare, memory, health literacy, everything we talked about before. And then here's the difference. The built physical activity facilities in their walking and cycling infrastructure in the middle there, those were only significant for lower socioeconomic status classes, which means it's very significant that they have these to improve more physical activity. Here's another figure, figure 3. It's associations of health-related correlates of physical activity in older adults by socioeconomic statuses. This is basically the benefits of the physical activity. As you can see, also very similar between the two. Depressive symptoms, perception of general health, weight status. Now, they did say that some of these outcomes weren't biased, like tested, so they don't know if they're really trustworthy, but even then, they'll have lower alcohol consumption. And then the only thing different between the two is that lower socioeconomic status people had less smoking when they had more physical activity. So here's table 2. This is essentially like a bigger outlook of everything we just went through, just like a general big summary. So basically, we want to focus on in this table is if you look at like the physical function at the top, you see like worse and better, and you see how it's positive. You just see there's a plus mark, which is positively correlated with the better outcome, which means a lot of these are for the better, like higher physical activity or whatever. Generally is a positive correlate, which is good. And we want to see this, right? Depressive symptoms, right? There's less depressive symptoms, there's less alcohol consumption. And then basically we went over before. If you see like the plus on the right, the plus with the star means only for lower socioeconomic status people. And as you can see, it's built physical activity facilities and get them more active, and walking and cycling infrastructures get them more active. Also, they have less smoking. Something to point out is there's a higher number of higher socioeconomic status people with a better perception of general health when compared to lower socioeconomic status people, which is just something I saw. And then also there's NS means not significant. So in conclusion, the SES gap in physical activity is driven by a systematic, opportunity gap, not by differences in individual motivation or the mechanisms that influence behavior, because many of the variables are the same. It's just whether they have access or not. And while many correlates are universal, the physical environment, facilities and infrastructures, is a uniquely significant factor specifically for lower socioeconomic status older adults. Connecting to other phases, phase 1, benefits of physical activity, less depressive symptoms, low alcohol consumption. And phase 4, factors that influence physical activity in this case would be like facilities and infrastructure, and also social perception, as we saw. Some practical applications for public health policy and urban planning. Prioritize investment in built infrastructure and low socioeconomic status neighborhoods. For community program developers, create and fund programs specifically designed to increase social participation and combat isolation among older adults. And for healthcare providers, integrate smoking cessation support with physical activity advice for lower socioeconomic status patients, recognizing the linked importance of these behaviors. For strengths of the article, they have high quality evidence, as a systematic review and analysis of like 77 studies. Findings are based off comprehensive, robust evidence base. It's a clear comparison is stratified analysis of low versus high, provides clear, actionable insights into socioeconomic disparities, and it's directly applicable. Results offer, concrete targets for policymakers and public health interventions. For weaknesses, causality cannot be proven. Mostly include studies where cross-sectional showing association but not cause and effect. And it's limited generalizability. It was very UK focused. Findings may not directly apply to countries with different cultures, policies, and or infrastructures. For the author's take on future studies, they said that future research must prioritize understanding why there are such large disparities in the prevalence of key positive correlates like good health and social participation between socioeconomic status groups. As you saw, the good health perception was widely big for higher socioeconomic status classes, which was like around 72 versus the low one, which is around like 50. To continue on, there's a need for longitudinal experimental studies to test whether the identified correlates are true and the causal determinants are suitable for intervention. My personal take, I agree. Longitudinal studies should be used to establish causal pathways between socioeconomic status and physical activity over time. We also need intervention trials that specifically test the impacts of improving the built environment and creating social programs in low SES communities. And future studies should use a systems approach to explore the complex interconnections between all these factors rather than viewing them in isolation. And thank you for listening.